You are listening to the Clinical Matters podcast with Lukas Fürhauser and me, Nicole Winitsky. Welcome to our latest episode.
Yes, welcome. Clinical Matters is brought to you by the European Association for Osseointegration, the EAO, a community of the leading scientific minds in implant dentistry.
The podcast Clinical Matters is all about celebrating the exciting developments in implant dentistry. In each episode, we bring you an amazing guest and discuss their research and latest thinking in the field.
And most importantly, this show is for everyone who wants to take away condensed practical knowledge they can apply directly in their daily practice.
Today, we have the pleasure of speaking with Dr. Duygu Karasan, a full-time faculty currently based at the University of Geneva. One of her focus areas is prosthetic complications in implant dentistry and how to avoid them. And we will, during today's podcast, go through this topic and we will talk about prevalence, etiology, and how to prevent prosthetic complications in implant treatment. Complications can, of course, occur across all types of restorations, single units, partial cases, and full arch cases. But we will today focus on single and partial cases, since this is where Duygu have performed most of her research and also have the deepest knowledge.
So Duygu, it's wonderful to have you on the show. It's really great that you're here. It's a great honor for us. Who are you? Could you give us a little insight in your personal life and your professional background?
It's a big honor for me, of course, to be here. And thanks for the invitation, Nicole and Lukas. I think this is one of the most interesting things that I am doing, a podcast recording. So thanks for having me. I'm a prosthodontist and reconstructive dentistry specialist, currently based in University of Geneva. I'm working in Division of Fixed Prosthodontics with Professor Irena Seiler since 2018. I came to Geneva in 2018 as an ITI scholar, and then I decided to go on my career here in Geneva, which also was supported by Professor Seiler. And meanwhile, I did my Swiss specialization here in Geneva, and at the same time, I am working as a full-time faculty member at the University of Geneva in the same division. I am originally from Turkey. And I was born in Turkey, and I studied in Ankara dentistry, and then I did my first specialization back in Turkey. So what brought me to Geneva was scholarship and actually excellent international organizations that are allowing people to move around and find new aspirations and mentors around the world.
Great, amazing. And could you describe your journey towards the field of material science you were researching?
I'm sorry, my light just went off.
Don't worry.
I'm so sorry.
Don't worry, it's not a problem.
Should have said it again. Oh my God, this goes out time to time.
Don't worry. I ask you again, okay? And
yes.
And Duygu, could you describe your journey towards working in the field of material science and your research?
So, I was super interested always about prosthodontics as a student, as a pre-grad student. And then when you start doing actually prosthodontics is quite fun. It's amazing to do. But at the same time, one of the challenges that you face, of course, the complications. And today, preventing complications is a big aspect of our practice, and not causing them, because we know that this might really cause long-term problems for our patients. And as we have longer follow-ups with our implant cases, we see more and more the effect of those complications.
Absolutely.
So it is really a factors that is, I love, of course, prosthodontics. I like doing clinics, and I like to really explore what could be the best practice for our patients. So, and this guides you automatically to this area of research, because one of the things that we had with the complications, of course, it was the material and the limitations of the materials that we had in the past. And technology plays a big role, industry plays a big role in how we are evolving and how we are changing the materials that we're using in our practice. So because of this, my interest in the technologies and my interest in prosthodontics, actually it just really pushed me to do more about the complications and how to prevent them.
Yeah.
I think this is a really special occasion that we have here, because we are now 3 prosthodontists in the same podcast, and that doesn't happen very often when it comes
Not
to
in
implantology. No. So I am so eager to really dig into this with the two of you. I would like to start because I was, of course, you were having a lecture at the EIO in Monaco, and you started this lecture, or the whole session started with a very interesting thing, and that was asking the audience, what complications do you see, or all of us out there, do we see most frequently? Could you please speak a little bit about what the answer was that came out there?
Actually, of course, we were focusing on the technical complications, so the question was more on the prosthetic side, and we wanted to have a feeling of what the audience is actually experienced in their practice, and it was really in parallel what we have also seen in our research and in our clinical practice. It is mainly the complications that are either discementation from the tie bases or fracture of the veneering material, if there is any, and the fracture of the restorations and screw loosening. So these are really main complications. And on the other hand, we didn't really focus on biological complications, but of course, the influence of prosthesis on the biological outcomes is also an emerging topic, and this was one of the topics that came up as well.
Today we have a way of dividing complications into 3 main categories. We usually say that we have the technical complications, the biological, and the aesthetic. Could you please describe the difference between the 3 of these?
The technical complications is the complications that are arising from either the implants itself or implant components or the reconstructive component, which is including the fracture of the restoration, chipping, screw loosening, or any component related complication. And on the other hand, biological complication is the complications that we're talking about, the living tissues around the implant, which includes the bone and soft tissues. And the third one is the aesthetic complications, which is the problems that we're having either with pink or white aesthetics of the restorations that we're delivering to the patients, the harmony of the restoration with the surrounding environment.
Could you please say something more about this with aesthetic complications? Because I've been doing some long-term research on single implants, and we also had the topic, of course, complications as a parameter that we looked at. But when I look at older research and scientific papers, you hardly ever talk about the aesthetics as a complication. Why did that emerge, and how did that happen?
So I think our expectations from implant therapies have quite increased, and this is of course in parallel with the expectations of the patients as well. But also we dentists are trying to deliver really high quality restorations. That is, when I say high quality, it covers also not just technical aspect or not just a tooth that is just standing there and functioning, but we would like to have a good, healthy gingiva around the implant, and at the same time, we would like to have long-term good outcomes with our implant therapy. So I think what I see the shift in the literature is that we're really focusing on having quite nice restorations that is in harmony with that is invisible in the mouth, and this includes, of course, the highest aesthetic possible. And how is your I'm curious, how is your observation on your long-term evaluations?
They are what we see is there are several we're not here to talk about me, but I did a long-term follow-up of 17 years, and we saw a lot of different complications occurring after this time. About 50% of the patients ended up with some kind of complications. A lot of them only small ones, easy to adjust. But what I'm taking with me from my research and what I think that we should be aware of, it is that complications will occur over time. But we need to make sure that the complications are in a way so that we can help the patients with doing something about them when they occur. So it's not like catastrophic failure. Exactly. Exactly.
And one more thing about maybe the change, the shift in our practice about now we are maybe focusing on more aesthetic complications is that when you look at the previous research, you see that the patient perception of the aesthetic outcome is not as meticulous as the dentist themselves. So, which means that the patient most of the time is not complaining about aesthetic outcome. So, but I think the patients are expecting more and more every day, and the aesthetic expectation of the patient is quite high.
Much higher.
Yes,
I think so too.
It is much higher, but I also think that we should bring with us that we see so much more than the patient does.
Absolutely.
So sometimes the patient aren't even aware of small things that we see.
Yes.
And it also, of course, depends on where in the mouth the complication is and everything. We could discuss this a lot. I think it's a really interesting topic, this perception between patient and dentist. And
it's very funny because we did a study about that. Who is seeing most? So lay people or dentists and or students, and we're pretty the same. Was not that different, really. If you look on the pictures on a single implant, so it's pretty interesting that also lay people seeing the same complications, and that's also interesting. And maybe what's also interesting, who were the most critical ones in the field of dentistry? Who do you think?
The most critical ones?
Yeah, so orthodontist, cons, prosthetic, or surgery. What do you think?
I would definitely say orthodontists are quite
right.
most probably diligent. I also see that from the research, and the prosthodontists, of course, and later on, most probably, I would put the oral surgeons most probably, like maybe afterwards.
Further down.
I mean, I think the details. I think the details that we are looking into is we are really coded as prosthodontists to respect the form of the tooth, and we really study the form of the tooth, the anatomy of the tooth, and there is a big aspect in what we are doing, and aesthetic, perception, and we're trying to improve our eyes to see better, to create more natural appearances. So this translates to most probably more awareness with the results.
Yeah. Really interesting discussion. Let's move on to the next topic on complications.
So we talked a lot about complications. What do you think, Duygu, is the key factor avoiding these complications? Is it material selection, design, implant position? What are the key factors? What do you think?
All of the above, I would say. Because now we know that actually implant is really is placed to support a prosthetic rehabilitation that is going to really perform well in biological, technical, and aesthetic aspects. Which means that position of the implant is one of the fundamental things that is going to influence all the outcomes, short term or long term. We know more and more that the technical and aesthetic outcomes of the implant reconstructions, this can be screw loosening or the aesthetic outcomes that we're having, pink and white aesthetics, is directly influenced by the implant position. If it is positioned correctly in 3D way, correct depth and mesiodistal and buccolingual orientation. So this is the first thing, which means that one of the most important thing is to plan implants correctly and prosthetically driven, I would say. And then it is like a chain of decisions that we need to make. Once we have the implant in correct position, we have the opportunity to use correct implant components, which is going to give us stability in terms of to prevent implant component complications, namely screw loosening. And also the material selection is the direct factor for final aesthetics. And at the same time, now we know that the use of monolithic restorations is going to significantly reduce the amount of complications that we're having, that we had in the literature in the past, especially the chipping, minor and major chippings.
Yeah. And of course, during the podcast today, we want to dig a little bit deeper into all of these topics. We would just like to set the record straight and just talk a little bit out of survival and what kind of complications that we see if we look at both single implants and also the fixed partial dentures. So if we start with the single implants.
I mean, when we start with the single implant reconstructions, actually the survival rate of single implants and restorations has been consistently high in the literature. So we know that actually the single implants are performing very well, and their technical outcomes are very good. But at the same time, there is still a way to improve it, because not just how successful we are at the end of the treatment, but also how easy to reach that outcome is quite important, right? So I would say the survival rates are excellent, but when it comes to the complication rates, if we are using traditional materials like veneered restorations, this can be metal ceramic or zirconia, veneered zirconia restorations, they have very high chipping rates consistently in the literature. And this high chipping rates has been reduced significantly that we have done in 2021 for EAO, the consensus paper, and we have seen that the chipping complication has reduced significantly with monolithic restorations. This can be either lithium disilicate or zirconia. So once we eliminate the chipping, actually for single restorations, screw loosening is less of a problem. But with the use of tie bases, now we have a different type of complication, a technical complication, which is debonding from the tie base, which we really need to pay attention. There is a recent ITI consensus paper that came out in 2023. We could see that actually the one of the biggest complications with tie base supported crowns is the debonding, which can be avoided very easily. How easily is that? To follow the correct bonding protocol according to the material that we're using for the bonding. So,
yeah. And do you think the height of the tie base is also a crucial factor? Because especially in times of very deep implants, this is really a hot topic, because our crowns are getting longer and longer and the tie bases are not growing that much. Do you think this is the problem?
That actually, we have suffered quite a bit because we have been in Geneva. We have been using tie bases very intensively since it was introduced. And
sorry, Duygu, could you just explain tie bases when you when you talk about that? What do you mean?
Of course. I use the term tie base. It's a titanium base that has a prefabricated abutment component that is engaging in the implant, but which allows us to actually create the emergence profile with the use of the crown that is cemented adhesively, extraorally, and then inserted in the mouth with a screw. So it is a restoration that is screw retained finally, that has two components, titanium base and the crown, but cemented only extraorally. So this is the tie base concept that we really like for certain reasons, because of the reason that we can use a prefabricated implant abutment connection while not really needing a customized abutment and costly producing aspect of the customized abutment. So we can customize the emergence profile with the crown, and then we can have the best of both worlds, right? And this is the concept. But of course, there is a weak link in this concept, which is the bonding interface. If the bonding is not done correctly, then it is quite likely that the patients are going to experience the cementation, the bonding from the titanium.
Do you have
base.
any numbers of this? How often this complication occurs?
I cannot really tell the number because unfortunately the research with the tie bases is not really, we don't have many researchers because it's a relatively new concept compared to the older conventional methods.
Okay.
But if you follow in our practice, if we follow the correct bonding protocol for the material that we're using, then we're experiencing very rarely the bonding. Your question, Lukas, for the tie base height, this we have studied, of course, this as well, because we have seen that when there is a lower height of the tie base, we were having some, micro movement and partial debondings, which is physically or mechanically is quite understandable. And then we have tested different type of abutments in different heights, and we have tested with the same crown height, and we have seen that actually the height is significantly influencing the mechanical stability of the crown. So which means that it is really effective. And I think the companies have understood this also more and more. And now we see in the market the abutments that are having, adjustable prosthetic heights that we can adapt according to the need of the interocclusal space and the space that we are restoring. So it's a very significant factor, and we really definitely need to use a highest possible prosthetic height of the abutment.
And that means that we also need to be very thorough about looking at the patient's occlusion, so that we have enough vertical space to do our treatments. Because I think this is something that we don't talk so much about. When we plan our treatments, it's really important.
Absolutely. I think the main thing, what is really critical, at least this is what I try to follow when I'm performing also the implant surgeries and restoring my crown. So this gives me the idea of, what I need to pay attention when placing the implants. And the opportunity to be able to plan the implants digitally and also already visualize the prosthetic component that we are going to use at the final restoration, it is the dream of any prosthodontist, I think.
Because then you can plan everything meticulously. Then you can plan everything from before you even place the implant. That's
absolutely,
that is a really good way of working.
And every component that I'm going to use, we are going to use is already done, and we can definitely see the emergence profile of our restoration beforehand, and optimize it to avoid also the biological complications and biological problems.
And do you have seen differences in tie base loosening between lithium disilicate and zirconia, or is it pretty the same?
Actually, if the surface treatment protocol that is applied correctly for zirconia and lithium disilicate is followed, then there is no significant difference in our research, at least that we have seen. And clinically, there is no data that I know of that is comparing the lithium disilicate versus zirconia. But overall, actually, the results with both materials is quite good and high. So, and if the surface treatment of the zirconia that is done correctly, which means that a good sandblasting has been applied to the zirconia surface, and MDP-based silane and the correct corresponding resin cement, and the surface treatment of the tie base is done correctly, which includes also sandblasting, definitely needs to be part of the protocol, then the overall bonding quality is quite good, respecting also the other mechanical factors, as you just nicely really actually mentioned, the geometry of the tie base and the occlusion and the space and the adhesive surface that we have. These are all influencing factors. And plus, if you have single crown but with an extension, with a cantilever, this is also an additional prosthetic factor that might cause some bonding problems. But overall, if we talk really particularly for the single crowns, I would say the best option as material is lithium disilicate and monolithic zirconia. That is new generation that we have in the market.
Can I ask something? I wanted to ask you about microveneering. That is something that I've heard you speak about. Could you please talk about what that is and why we should use that or why we shouldn't?
Honestly, this is when we were preparing the consensus systematic review in 2021, we have been focusing on the monolithic restorations, and we wanted to really have some outcomes for monolithic restorations, either lithium disilicate or zirconia. And what we have realized actually in the literature, there is a really heterogeneous reporting on the veneering, because some of the papers have mentioned have categorize their restorations as monolithic, but at the same time you see that they are doing some veneering on the buccal surface and so on. So we have identified in our paper how we are perceiving the microveneering and monolithic and what is the difference. So for us, microveneering is maximum 0.5 millimeter of veneering porcelain, that is feldspathic usually, that is applied only on the non-functional surfaces of the crowns, which you can categorize the incisal edges, occlusal surfaces as functional surfaces, which means that any load-bearing area on a crown is not going to be veneered to avoid the chipping. The veneering is only done for the aesthetic surfaces to improve the optical aspect of the crown. So this is how we define the microveneering, and this is something that we are actively using and doing. And also we are doing some research in the division to compare actually if chipping is improved with this kind of restorations or not. But so far our experience is actually if we avoid functional surfaces, then it works good.
So just to explain to maybe our younger listeners that may think that this is something that is very clear that of course we should do. We come from an era where we actually covered the whole crowns with veneering porcelain. And this is what ended up with giving small fractures here and there. So that's why we now want the functional areas in the stronger full zirconia or maybe full lithium disilicate materials.
Maybe I also help help the audience a bit talking about how we arrived to the monolithic restorations and why we don't need to veneer them any longer. That might be interesting as well, because
Yes, please.
I mean, material science is evolving, and the materials, they remain the same in name, but they also change and evolve. And zirconia is one of the materials that has really improved over the years. And initially, the zirconia that we have used in the past, 3YTZP zirconia, which is very opaque and only could be used as a framework material because of the aesthetic problems, and it was like a metal framework that we would do metal ceramic restorations and completely veneered with an aesthetic ceramic. But today we have the zirconia that has better optical properties, which means that higher translucency and gives a better optical appearance that mimics the tooth, which means that we can leave the zirconia without veneering, without compromising the aesthetics. And this is why actually the practice that we are doing and the transition to the monolithic restorations could happen. And a bit maybe the storyline goes like this, and we no longer need to completely veneer and cover the zirconia with veneering ceramic.
So if I, as a general dentist, order a full zirconia crown from my dental technician, what kind of zirconia can I expect to get then?
And that's also something very crucial, because now we have zirconias that are almost at the same mechanical properties as lithium disilicate, which, because as we have zirconia, and zirconia is stabilized with yttria, and the amount of yttria that we have in zirconia is also influencing the translucency and the aesthetics of zirconia. So now we have the names as 3YTZP, 4YTZP, 5YTZP zirconias, or third, fourth, fifth generation zirconias, right? And these are all actually the explanation of how zirconia is processed and how strong they are. So in some of the companies that have zirconias that are labeled as super translucent, extra translucent, super high translucent zirconia, and those zirconias are not to be used as 3YTZP zirconia as for posterior areas or load-bearing areas. So it is quite important for every general dentist or dentist to communicate with their technician and understand what type of zirconia the technician is using, especially the brand of the zirconia, and really communicate and make a guideline for different indications, what type of zirconia is going to be used. If I'm doing a posterior single crown on a molar side, then I want to use that zirconia. Or if I'm doing an anterior crown, then we can use a higher translucent zirconia. In our practice, what we are really opting for is actually the zirconias that are multigraded, that allows us to have actually the strength of 3YTZP zirconia at the cervical area, and higher translucency on the incisal areas, which improves the quality, the aesthetic quality. So I would really recommend to use this graded zirconias, because they are not solely the color aspect, but also they are produced to have different mechanical strength on each layer. So this would be my go-to material for anterior and posterior reconstructions, honestly.
But maybe also when we talk about this, we should move on to or include a little bit the discussion about bridges or fixed partial dentures, because would you think the same way for single units that you do if you have several units?
By the way, before passing to the FDPs, maybe we haven't talked about lithium disilicate enough for single restorations, because in our review, we have seen that actually lithium disilicate has performed even better than zirconia in single crowns. So lithium disilicate is a very good alternative in anterior and posterior cases if it is single crown, of course. And this is important to know, because if you would like to do multiple reconstructions, that is including, for example, tooth and implant supported reconstructions, and if you would like to have the good color matching between other restorations, maybe with your veneers or more aesthetically demanding restorations, then lithium disilicate is a very good option for posterior and anterior single implant crowns. And when we pass to the FDPs, of course, the whole consideration changes, because the mechanics and the strength that we need is completely different, of course. And for this, I would say for FDPs, for example, we have less problems with certain things that we don't have with single crowns. But at the same time, we are really limited with the material selection. Today, if you would like to do an all-ceramic reconstruction for FDPs, and if you would like to go for monolithic restoration, monolithic zirconia is the only material that we can recommend, actually.
Mm-hmm. And do you use multi-unit abutments for your FDPs, or you are screwing directly on the implant? What is your opinion about that?
This is a topic that I was quite surprised to see very little studies in the literature, both in vitro and in vivo. So this is something that I'm always questioning, because one of the most common indications that we do in implant dentistry, right? 3-unit bridge, and unfortunately, there is not a clear recommendation that can be taken out from the literature about what type of abutment to be used, and what is the best option as the connection. So first of all, we know that if we are using a multi-unit abutment, we need to use double screw, which is questionable because of the double screw system requires a second screw that is, less strong than the primary abutment screw, and we can only torque it until certain values, which then, as we don't have cross-arch stabilization with the 3-unit posterior bridge, for example, then what are the chances to have screw loosening is unknown, and it depends on a bit the personal experience of everyone, right? I use multi-unit abutments in some selected cases, but there is the fact of the cost of multi-unit abutments. So because it requires double abutment, and which is increasing significantly the final cost of the restoration. And if we can avoid using multi-unit abutments, cost-wise, this might be advantages, but then we need to have really good and nice tie bases that are stable enough that is not going to have screw loosening, or that they are not going to have decementation. Because the older generation of tie bases, especially the bridge tie bases, if you remember, they were quite conical or they were super short, and there was a high level of decementation with those restorations. But today, now we have more engaging bridge abutments. Then they seem to be more stable, but still research to be done, and we are working on it, I must say, and I'm really curious on what we are going to see eventually, because I cannot really find from the literature enough information on it. we talk about the single crowns, we talk about the full arches, but we are really talking about the FDPs very little. And this really bothers me, honestly. But these are the reflections that I have based on my research and my practice, but nothing that I can report scientifically at this moment. But what I can say, at least the multi-unit abutment gives the stability to the soft tissues around it is better and nicer biologically. But again, if we have high interocclusal space and if we have high crown height for FDPs, then the second screw is something that I concern. And I would rather solve it with a tie base that is nicely designed. And now I have a couple of I see a couple of nicer designs in the market for a bridge tie bases that seem to be promising and to be tested.
Mm-hmm. But I also want to add something there when talking about tie bases on bridges, and that is that it's really, really important that we place the implants good in relation to each other, right?
Absolutely.
Could you just mention something about that?
I mean, honestly, I think every implant reconstruction and every prosthodontist should definitely be involved in the planning of their implants. And the implants needs to be placed correctly for whatever restoration we are going to do. Because if the angulation is not correct, if the depth of the implants are not correct, it is really hard to solve some of those problems prosthetically, and everything that you try to do prosthetically is going to compromise the technical aspect of it, right? Because if you need to use an angulated abutment, then there are some certain concerns on the angulated abutments, even the tie bases. And if you have very deep implants, then maybe you will need to solve this with customized abutments. And if you are not able to solve it with customized abutments, then you're going to use an component that is not ideal for the situation. And the worst case, maybe you will need to solve the situation with a cement retained reconstruction, which then we know from the literature and we know from our practice that is really hard to clean, especially under the FDPs, the excess cement. And then we have higher chance to create biological complications over the time. So, I mean, implant planning and implant position is the most important aspect of implantology, and we cannot really separate it, prosto and surgery. No. It is just one planning that has to go across. If there are different people involved, there are different specialists involved, it should be just one project that is designed and done across different expertises. And if you're anyone placing their implants and restoring them, they have the chance to really plan according to whatever reconstruction that they're going to do.
Yeah. And Duygu, we talked a lot about ceramic, lithium disilicate, zirconia. Do you think that we talk in 10 years still about monolithic ceramic as a gold standard, or will it be a resin printed or a ceramic printed? What do you think is the future?
This is one of the things that I think it's quite important to understand, because the reason that we can use today the monolithic restorations is because of the improvement in material science, right? And this happens because of a need, because it's an outcome of the whole trend that is happening. Because every dentist, including me, you most probably, that we would like to solve our cases in a more efficient way, which starts with the planning and impression, and we would like to finish it. And at some point, we would like to also do some restorations that are fast and maybe chairside. And monolithic restorations allow us to actually eliminate some of the steps, like maybe analog models, veneering that the technician is doing. And also at the end, we can eliminate the factors that is coming from the quality of the manual work of the technician, that we can have a restoration that is designed and produced correctly, right? So this is something that is clearly happening, and it is not by chance. It's a trajectory. And if I see this trajectory in a way that, I'm not going to make big comments here that is, we are going to have this or that in the future. But what I see also in what I do research on is to really reduce the appointments. I would like to really solve my cases. If it is a single implant case, I would like to solve it not like place the implant and then do the reopening and then take the impression and wait, maybe do a provisional shape the gingiva. No, I would like to, if possible, already preserve the emergence profile and have maybe one session restoration eventually. And this is also has been shown that it is something that improves the health of the soft tissues around the implants, right? One crown, one time, one abutment, one time concepts. And when I see this trajectory, I see that the 3D printed options are very interesting, and they are improving. And what I could say, there is not enough data that we can say, yes, now you can use for definitive solutions, nanoceramic composites that are in market for restorations. But what we can say, it is worth to try, and it's worth to experience actually what is the lifespan of a restoration that is 3D printed. Because maybe we don't need to give the patient a crown that is going to last 15 years. Maybe if we can make a crown that is less costly, then we can redo it every 3 years, or maybe there is a lifespan. So this might
maybe
be
adapted to the new situation. Yeah.
Exactly. Yeah. So this might be a shift in how we see the success in prosthodontics and in implantology. And I believe we are going to, like in 1 or 2 years, we will have a bit more answers on how those restorations might behave. And because it's not like, yeah, it is cool, let's try it. No, it is a need that we need to tackle.
Duygu, it's been really so exciting, and we could talk to you for ages. We could keep on doing this for another hour or two, and we would love it. But I think we're more or less running towards the end of the podcast. But is there anything that you would like to say to the listeners out there? Is there anything that you feel that we missed that you would like to bring up in the sentence of prosthetic complications?
I think you guys asked all the correct questions, and I hope that I could answer them. Maybe not. I hope they were not too generic, but hope it will be helpful for the listeners. But what I would like to say is that we have very long time we have seen implant prosthodontics as, eventually we did a prosto. So not really important part of the whole treatment. But actually today we see that we do everything actually to have a restoration to give the patient function and aesthetics. So the main objective is the reconstruction. And to be able to have a good reconstruction, the planning and everything has to be done based on this end plan. And I would like everyone to really a bit maybe think when they're planning their implants or when they're referring their implant patients to a specialist to to really get involved in planning. And planning is the key for implant success, both technical, biological, aesthetic, and the rest is to choose the correct material. You don't have to use every type of material, but identify one material per indication and routinely use it, and communicate with your technician and with your team on very critical aspects of the workflow, like choosing the correct zirconia type, choosing the correct bonding protocol. These are going to improve your practice significantly. That's for sure.
Lukas, is there anything that you want to add?
Maybe one last thing. Cantilever. Is this a problem, do you think, or not?
Cantilevers has a really specific biomechanical behavior. It is an extension on a abutment tooth, and how actually it affects the whole component is quite interesting, and it's a bit biomechanically disadvantageous situation overall. And when we are doing a cantilever, of course, everything gets more risky, which means that we need to pay more attention to certain things that we are more comfortable with single crowns or FDPs. Namely, if you would like to use a cantilever in the anterior area, that is, let's take the situation, 2 missing teeth, central incisor and lateral incisor. We are placing one implant to the central incisor and making an extension to the lateral. In this case, we can really avoid the occlusal forces on the cantilever area, and we can really actually reduce the risk and potential complications. But and this is a very actually safe solution and a recommended solution in order to avoid also the aesthetic complications, right? But when it comes to the posterior area, now we are talking about high load-bearing areas. If it is 2 premolars that we are restoring and 1 premolar implant and 1 premolar extension, then this is still can be less problematic. But if we are replacing a molar with a cantilever in the posterior area, we need to pay attention to certain things. First of all, if we would like to use a zirconia material, then we should know that we don't know how zirconia is performing under this kind of cantilever situations. It looks promising. So far, we are doing research and RCT in the division. It looks promising that the mechanical failure is not really common, but at the same time, the load on the implant is actually quite high. And we have always said, okay, the implant bone loss or implant loss is not exactly correlated with the occlusal load, but I think this is something that we really need to pay attention to avoid the overloading of the implants, and the implant diameter is quite important. The thigh base geometry is quite important, and when we are using a cantilever, not really high crown height, and also not more than 7 millimeter of cantilever. That should be like the guide rule.
Mm-hmm. And you always use, also in the aesthetic area, you use monolithic zirconia here, not disilicate.
If it is cantilever, yes.
Yes.
Not lithium disilicate. I mean, we use a cantilever for resin-bonded bridges, but not for implant reconstructions.
If I could just end, I would just like to do a little recap of the 3 most important things that I think that we spoke about today. The first one is failing to plan is planning to fail.
Absolutely.
The placement of the implants is really what sets the requisites to do good prosthetics. The second is that I think that everyone should be aware of the more translucent zirconia we use, the weaker it gets, so that we
Yes.
don't mistake us with that. And then something else that I think is important is the occlusion, or the vertical dimensions. We need enough vertical space to be able to make strong enough prosthetics so that we can reduce the risk for complications, because that is what we want to do with all of these things that we've been talking about today, to reduce the risk of complications.
Absolutely. Very nice recap.
So, Duygu, it was a true pleasure to have you. Lukas, thank you very much for a nice podcast session. And to all of you that have been listening to the EAO podcast Clinical Matters, thank you so much for joining us this time. And we hope that you would care to join us even the next time.
See you next time.